Okay, so let's go ahead and now talk a little bit about tuberculosis and HIV. Again, just trying to emphasize the points that the transmission and pathogenesis is important, but really nothing has changed the pathogenesis or the transmission of TB or the TB epidemic as much as HIV has in the history of mankind. So this first X-ray should look familiar. It was on the previous presentation. Thank you. So this is usually the point where I start coughing and the front row starts to clear out, so you guys don't have to worry, you're too far away. So this chest X-ray is again of a patient who had active TB disease, who is HIV positive. Why did the X-ray look this way, and what is it? How can that be picked up immediately? This is a patient who had miliary disease. This is that patient that I showed that was from sub-Saharan Africa who had disseminated disease. Again, will this be picked up earlier on? She'd been sick for several months and had a relatively normal X-ray up until about the time that she was diagnosed. Again, very difficult and presents some significant challenges to move forward. So as I like to do, I like to set the context and talk a little bit about the epidemiology of TB more in a global context, but also how it relates to HIV. And just to put things in perspective, we didn't talk much about this already, but there was an interesting article in the paper today where one of the local middle schools celebrated the birth of the 7 billionth person on Earth, and I'm sure you guys heard similar things as well. How they figured that out, I have no idea, and I wouldn't want to carry that burden and say, hey, you're number 7 billion. But anyway, the point is that 1/3 of the world's population is infected with latent TB, which is enormous. I mean, 1/3 of the world's population is PPD positive. And that's stunning when you think about how many people that represents as being active cases. It leads to about 8 to 10 million active cases of TB per year. There's a case prevalence hovering about 40 million cases annually that have TB walking around, not new cases, but people who have active disease potentially spreading to others. And this leads to just below 2 million deaths per year. In the U.S., you can see that the numbers are substantially better. All of the states are recording record lows with active cases. In 2010, the incidence in the United States was only 11,000. That represents less than half of the total number of cases when I started working in TB 14 years ago. But we still have significant deaths, and this is a global disease, and as sort of a World TB Day motto from a couple of years ago, until TB disease is eliminated everywhere, it's not eliminated anywhere. And you can see that when you look at the number of HIV co-infected cases and the impact that that has. 1.1 million new cases per year of HIV co-infected. And what percentage of those do you think actually get the adequate care both for their HIV and their TB? How many of those do you think have MDR? We don't know, but we know that the percentages are nowhere near where they should be, and they continue to grow in many places. I'll talk a little bit about how difficult it is to control TB in the setting of HIV. But just know that 40% of all cases of TB in Africa are HIV co-infected, which is remarkable. In the United States, fewer than 700, or about 700, or about 6% of all of our cases are co-infected. That is a dramatic change. In Florida, where we have higher HIV rates than many parts of the country, we were at about 21, 22% HIV co-infection when I started. Now we're probably hovering about 8 to 10% HIV co-infection. So those rates continue to go down, largely because of very effective latent TB therapy amongst HIV-infected individuals, and also heart therapy, which has been very effective in reducing opportunistic infections in HIV patients. So we talked about kind of the 1/3 of the world, and we kind of went through this, but just sort of put things in perspective. I could throw those numbers around, but just imagine a 747, a jumbo jetliner crossing the Atlantic, crashing on the hour, every hour, 24 hours a day, 7 days a week. 365 days a year. That is about 1.7, 1.8 million people. And that's a tragedy that, would get our attention when one plane crashes, but this is happening every day with regard to TB. It's continuing to be a big issue, and although it continues to reduce in the U.S., we still are going to see increases amongst the foreign-born population, and we'll continue to battle this disease as long as it's a problem everywhere else. The rising incidence of drug-resistant disease around the world is going to ensure job security for a lot of us, unfortunately. So the WHO TB incidence, we talked about this and kind of highlighted the areas. Again, what's driving the epidemic in the highest incidence areas of the world is HIV. That's particularly true in India, which is sort of in the mid-range here, but still very, very high, with some pockets that are exceptionally high. Epidemiology of HIV on a global scale. You can just see what the numbers on the column on the left are numbers in thousands. So you're talking basically millions and millions of individuals who have HIV, and the epidemic continues in some places to grow. And where it's not growing in some places, it's because all those that are at risk have already been the epidemic has been saturated. Fortunately, in some places, actually many places, particularly in Southeast Asia, educational campaigns, behavior modification, other public health initiatives have really resulted in a marked decrease in the transmission of HIV, and so there is hope to sort of stem the tide. Here in the U.S., the epidemiology of HIV, there's more than 1 million people who live with HIV in the United States, and about 50,000, or on the statistic here, 56,000 new HIV infections annually. Still, there's some very high-risk behavior that continues on. 4.7% or 47% of men who have sex with men engaged in unprotected intercourse in the past year, and there's still sharing of syringes amongst IV drug abusers, and that's where our 56,000 cases largely comes from. So it continues on. So still, there are some challenges. Behavior modification, education can only carry you so far, and you're still going to bear the brunt of some of the challenges with these dual epidemics. Now, what about the prevalence of HIV co-infection amongst new TB cases? Again, the hotspot is sub-Saharan Africa, but in Latin America, there's some very important parts, especially within the Caribbean. That's particularly important for us here in Florida, but again, it's a large issue globally because of many of the similarities between the Caribbean and sub-Saharan Africa. Now, TB cases, before I kind of give you all the gloom and doom, TB cases are falling in 6 of the 9 regions of the world. And where it's not falling, however, is in Africa where there's a high incidence of HIV. So the rise in incidence is slowing, but that's kind of trying to find the silver lining in what is a very, very dark cloud. We need to continue to step up efforts to address the co-epidemic of HIV and TB. We looked at this last slide in the last presentation, and that we're doing a good job. We've been able to invest in a good way, and actually the reporting of HIV test results in the U.S. has gone up exponentially, not exponentially, but significantly since 1993. HIV co-infection with people with reported TB continues to go down. A lot of this has to do with the good work and the hard work that many of you have done, both in Alabama, all throughout the U.S., where we've been able to get very effective latent TB infection therapy to those at highest risk. We've interrupted transmission and also got people that are at risk on appropriate therapy for their HIV disease. So now you're looking at about 6% of the total. Still in that high-risk 25 to 44-year-old age group, we still have just over 10% of patients with TB. In that age group, we're going to have HIV co-infection, but still it's markedly better than the 20 and 30% range that we were seeing in the mid-1990s. But here's the thing that drives the bus with TB in the U.S. I don't want us to forget this, even though we're talking about HIV and we were talking earlier about transmission and pathogenesis, is that TB is a disease, a global disease. And it is a disease in the U.S. increasingly of the foreign-born. We need to find ways to make sure that we incorporate all of our strategies to reduce the TB risk amongst the foreign-born and also to screen them appropriately before they even get into the U.S. There's a lot of work to be done here. And again, it goes outside the scope of what I want to talk about today, but this is a very important issue for us to address. So as we talk about, we sort of set the table there, and now we want to talk a little bit about the clinical presentations. I hinted at this before in the earlier talk, but I want to show some examples of how the x-rays can be different and how the presentation is very different. In this case, you can see that this individual has evidence of significant mediastinal adenopathy. There's really no infiltrate per se, but they have large areas of adenopathy. This is an HIV positive individual who is 3+ positive for MTB. So a lot of infection, not a lot of parenchymal disease, but they can't mount an appropriate immune response. So radiographically, they have a very different appearance. A patient that has some atelectasis with some associated pleural effusion on the right. Pleural effusions are very common in HIV-positive individuals with active TB disease, and an HIV-positive patient who has a pleural effusion needs to have TB ruled out as soon as possible. Now, again, most patients, and I say many, but actually it should be most patients are going to have the classic symptoms of TB. But just bear in mind that a lot of patients are going to have very few symptoms or very vague constitutional symptoms. I've got kind of low-grade fever. I've been losing weight. I feel a little bit sick. Again, things that are vague that really don't help us. But just remember, HIV-positive patients, especially in the Southeast, you need to worry about active TB disease. Many HIV-infected patients are going to have very atypical chest X-rays, as I showed you earlier, and even may have completely normal chest films. Again, it's unlikely, but it's going to be correlated directly to their CD4 count. If they, the lower the CD4 count, the more likely they are to have very few findings on chest X-ray. HIV-infected patients with TB are less likely to have cavitary disease, and that's important because the cavities are formed by an intact immune system. Cell-mediated immunity, it's not toxins from the organism itself, it's actually the body's immune reaction to the TB itself that causes the evidence of cavitation. And remember, up to about a fifth of patients, fifth to a quarter of patients with HIV can have normal chest X-rays. That's not as true now, but it can certainly occurs. Extrapulmonary disease, a large percent, more than half, are going to have extrapulmonary disease. Normally, it's about 15% of HIV-negative individuals that are going to have extrapulmonary disease. So that's everything from lymph nodes to abdominal disease to pleural disease. If you look at the UK system in the US, we don't consider pleural disease extrapulmonary, but in the UK and WHO they do. But you can just see that there's going to be a lot more dissemination. So you can't control the infection, so it progresses on much faster. You're going to have other parts of the body involved. It could be anywhere. And just remember that any non-resolving infection, any non-resolving issue in an HIV-positive patient could represent TB. This is an example of TB within the spinal cord. This patient actually presented with paraplegia, if you can believe that. So they just had this mass, this sort of lit up area right there in the middle. If this is the tool to mark. Yeah, I'm having a little trouble getting the pointer on here. Is that it right there?
Mike, you have to hold down your left mouse button while you're doing it.
Yeah, for whatever reason, it's not working here for me, but that's okay. So anyway, if you can look within the spinal column there, just behind the vertebrae, there's a wider pale area that is actually a mass within the spinal cord, a tuberculoma that presented with paraplegia in this patient. Now let's move on from the actual clinical presentation of active disease and talk about the diagnosis of latent TB infection, because the long and the short of it is that most of you are not going to be treating patients with active disease, active HIV disease. You're going to diagnose latent TB infection amongst HIV infected and deal with latent TB far more than you will active disease. Now it's hard to believe, kind of going back, and I told you I was a history buff. It's that Robert Koch, who identified the bacillus that causes TB, he was like a rock star. He was like a rock star at the turn of the last century. And they actually had posters, they made movies about him. I mean, there's just this amazing kind of history that when you kind of think about the attention that we pay to entertainers and sports stars, it pales in comparison to the attention that they gave these individuals back then. And makes you wonder who really had their priorities straight, but that's a whole other discussion. But talk about sort of the LTBI diagnostic tests that have been developed in the 20th century. And think about it for a minute. So Robert Koch was in about 1890, 1892, actually 1882, sorry. And there's been absolutely nothing in the 20th century to diagnose LTBI, which is remarkable. When you think about it, it's the most common infection in mankind. And we've never developed a single test other than the PPD. And it's not because the PPD is that great. I mean, it's a decent test, but it's very limited. And yet we did nothing over the entire 20th century. Enter the early 20th century, 21st century, and we'll talk about the IGRAs here in a moment. But just to kind of briefly review about the PPD skin test, I put this slide here to just emphasize that what I find is that I trust you guys. I trust people who place PPDs all the time. I trust the nurses that I work with and the health departments that I work with as well. But I don't trust those that place PPDs very intermittently, that haven't done the training, that do it because it's an office requirement and they're just getting it done, and somebody who's doing it because a patient needed that done and it's one of the 20 things that they're going to do. There's a technique. It's a limited test, but there's a right way to do it and a wrong way to do it. And I think stressing that is going to be important. And I also want to stress that when you do have a patient, especially an HIV positive patient, any symptoms of TB disease, regardless of their skin test reaction. So if their skin test is negative, you've not ruled out TB, and emphasize that to your private providers, because that is an ongoing issue. Despite all the education that we may provide, there's still a belief that, well, I've ruled out TB, the PPD is negative, and there's really not much more left at this point. Okay, so now what happens in HIV positives? They develop anergy, but anergy testing is not recommended. It's not recommended for HIV positives, people on immunosuppressive drugs. There is no real role for anergy testing in the face of a positive or negative PPD. It's just not needed to be done. If they don't react, they don't react. You can't give yourself a sense of security by doing the anergy testing. There's a lot of reasons for that, and I'll get into those later. Well, let me talk about this. This is a, I think, 42-year-old woman with a past medical history significant for diabetes, was diagnosed with HIV 2 years ago but didn't have any follow-up, but had been exposed potentially to TB in the past, but you're not really sure. Should you do a skin test, or should you do an IGRA, the interferon gamma release assay? This next patient is a patient, I forget how old she was, but this is another patient who's HIV positive. She has symptoms of cough and was exposed to a case of active TB a year ago. X-ray is relatively clear. PPD was negative. IGRA was negative. Are you done? Has active disease been ruled out? Has latent disease been, latent infection been ruled out? I think the IGRAs and the PPD test both have a role in sort of answering both of those questions, but you always still have to consider active disease in anyone who has symptoms. But let's talk a little bit about the IGRA. And again, I know that this topic has been beaten to death for a lot of people, but I think it bears mentioning here, especially in the setting of HIV. The IGRAs, or the interferon gamma release assays, are whole blood tests that can aid in diagnosing TB infection. And it has a very minimal role in TB disease, but I put that there for the reason that I want you to bear in mind that there are a lot of private providers out there who have used these tests to, quote-unquote, rule out active TB disease. It does not rule out active disease. This is a test for latency and latency only. So just bear in mind that this does not adequately rule out active disease. It's part of the puzzle, and if it's positive, it helps you, but it does not rule out disease. 3 IGRAs, they have been approved, but really only 2 are used. There's the quantiferon golden tube, and then there's the T-spot TB test. Those are really the only 2 IGRAs that are used in the U.S. and actually commercially used anywhere in the world right now, is my understanding. Here's a copy of sort of their package inserts. Some general points about them. Basically, it's a whole blood assay that allows you to draw blood and allows you to just, with one test, one visit, say if someone has latent TB infection or not, with some very important caveats that we'll talk about. They are not impacted by BCG, so that's very important. They also have a moderate to high sensitivity, but just remember, I said before that 90% of PPD positive individuals do not progress to active disease. So is that really a good test? I don't care about those 90%. I want to know who amongst those 10 are going to progress, and how to identify those 10. I don't want to know all the PPD positives. I don't want to know all the IGRA positives. I want to know who's at risk for progressing to active disease. We still don't have a gold standard to know who is PPD, who is truly latently infected and who is not. And trying to sort that out, we're still trying to do that with the IGRAs and seeing what role that they may have. They're sensitive. T-spot may be more sensitive in the immunocompromised and may have a more important role in the most HIV positives, but that is still not completely clear. IGRA, significant advantages. One single visit, you got the results in 24 hours. It doesn't boost the immune response, so you don't get sort of that boosting effect that you may get with PPD. And prior BCG vaccination does not cause a false positive result. This is very important for us. I'm assuming that in Alabama, similar to here in Florida, where we have a nursing shortage. And so many of the nurses that work in our university hospital have been recruited from high incidence areas, namely the Philippines. And so the repeat testing is very important, and IGRA testing to discern between PPD positive from BCG versus PPD positive from exposure to true TB as part of their job. Disadvantages of the IGRAs: blood samples have to be processed within 8 to 16 hours after collection. Those white blood cells still need to be viable, and you can't do that if you just store it, put it on the shelf, and do it the next day. There can be errors in collecting and transporting, and there's limited data to say who's going to progress to active disease. We really don't know and don't completely understand that. So I think that's an important limitation, but still overall helps us a great deal. Where it's limited is that we don't have a lot of data on HIV positives. We don't have a lot of data on children younger than 5. We don't know what the role is of serial testing. So if I do my skin test now, or do my IGRA now, I get exposed to TB, it's positive. I take LTBI therapy, it stays positive, but then it becomes negative later. What does that mean? Or I'm PPD positive now, I'm IGRA negative now, I'm IGRA positive later, and then negative again before I even start therapy. What does that mean? It's still unclear. That sort of conversion and reversion is still a little bit gray for a lot of people. An important thing is that the test might be expensive, but I don't think that that's a very valid concern, because when you look at the amount of time it takes to do the PPD and time away from work and repeating and all the extra inefficiencies built in, I think the IGRAs are much more cost effective, and there's significant data to show that now. So what tests should be used to diagnose LTBI? This is the bottom line. What do we really need to know? TB, as we talked about, is a very common opportunistic infection amongst HIV, and it's the leading cause of death. And so how do we figure out which one do we use? How do we know what test? So there's been a lot of attention sort of looking at guidelines about what to do because of the big impact and the importance of LTBI amongst HIV positive patients. And there's a lot of things that are out there, but probably the best one is referenced here, and I would encourage you to sort of pull this paper. I think it's a paper by Madhu Pai up in Montreal. They did a systematic review that kind of looked at whether or not IGRA should replace the TST, and what they basically came up with was that really there's not enough data to support one or the other. There were 37 studies that had over 5,000, almost 6,000 total patients. They found that the risk of active TB disease was greater in HIV positive individuals with a positive versus a negative IGRA results. Not terribly surprising there, but really there was not enough evidence to say which one was better than the other. My preferences is that I do a TST and I do a TST and then I do a T-spot afterwards in HIV positive if it's available. But either test is acceptable. There's no proof of one being better than the other. But really, with HIV positive patients, the decision to treat is going to be important regardless many times of the PPD or IGRA status. There's more work that needs to be done there, and it helps you if it's positive, but if it's negative, you have to assess whether or not treatment of LTBI is going to be necessary. And it's a perfect segue for this next part. You guys might remember our little guinea pig friends picture that I showed here, but also the poor guinea pigs, not only were they put in cages over patients with active TB disease, but we decided to be fair and then also give them the effective doses of INH and figure out what those were appropriate. And actually found that they were, the dosing came out to be about 5 milligrams per kilogram. There's not a lot of evidence of what the best dose is in humans. There's a little bit more toxicity with the higher doses, and that was shown in some subsequent phase 2 studies looking at INH. But basically, the guinea pig studies form the basis of that 5 milligram per kilogram dosing that we do so commonly in humans, or we do routinely in humans. Clinical trials looking at the efficacy of INH in HIV negative people. These were the first real clinical trials that were done anywhere in the world. They were large phase 2 and phase 3 studies that had a substantial impact on clinical practice and how clinical trials would be run. These patients had over 100,000 participants. I mean, they were enormous and were worldwide, and showed that there was significant benefit. Now, if you took INH, you basically were protected. You had as much as a 90% reduction in your risk of developing TB disease after you took a full course of INH, and that was 1 year's worth of INH. Interestingly enough, in all those early trials, there were no cases of hepatitis reported or more likely recognized. It must have occurred, knowing how common it is now. This slide sort of summarizes all of the trials that looked at the varying rates. This was the IUAT trial, from 1969 to 1977. and goes to show increasing in protection with decreasing the 5-year tuberculosis incidence rate with taking up to a year's worth of therapy. And talked about the fibrotic lesions and the increased risk for the sort of latent state in sort of the setting of fibrotic lesions on chest X-ray, and showed overall a reduction of risk. But enter 1971, after about not even quite 10 years of LTBI therapy with INH, there was a very infectious case up on Capitol Hill, large contact investigation, a lot of people, congressional staffers, some members of Congress, journalists were involved, and over 1,000 people were started on INH. Within months, there were several cases of severe hepatitis, and there were 2 deaths. Both were journalists. So, you know, that had a lot of press and it got a lot of attention, and probably rightfully so. I mean, there was not an identified risk factor for treatment with INH, and then that was finally pointed out. So because of that, the idea was that we need to reduce the amount of INH. INH was bad, and then there was this idea, and this sort of erroneous idea, that it was only based on age. And then it was also based on duration of therapy. So we then went down to 6 months of therapy, but then George Comstock, one of the sort of pillars of TB and public health in the last century, went back and looked at his original studies in Alaska and found that the maximal benefit was achieved, almost maximal benefit was achieved in 9 months. So it really wasn't based on cost effectiveness, it wasn't based on overall effectiveness, it was just the most efficient use of INH was with 9 months. And hence we have our 9-month regimen now. So this is another chest X-ray. This is of a patient who has a normal film but has symptoms and is HIV positive. Is this someone you would go ahead and put on INH therapy? No, because you've not adequately ruled out active disease. So bear in mind that ruling out active disease is going to be critical. Again, this is another X-ray that shows fairly extensive disease in an HIV positive patient who has the dense area consolidation in the left upper lobe and some more fibronodular stuff over to the right. Notice that there's no real dominant cavity, although there is some necrosis, but you don't have a lot of, you don't have evidence of miliary disease and no basilar disease present. This is that slide I showed you earlier with the sort of right paratracheal adenopathy and clear lungs, but yet smear positive specimens. So let's talk about other options for treatment of latent TB infection, both in HIV positives and HIV negatives. Rifampin monotherapy for 6 months for context in an INH-resistant case. This is a study that was published about 15 years ago that looked at homeless people in Boston and got only documented TST converters. And of those who received no therapy, 8.6 developed acute TB disease. I think was within 1 to 2 years. I think it was within 1 year. On the 38 that were given INH despite INH resistance, because they didn't know that later, they were not really sure what the role would be, you had a similar, slightly different, but still not significant difference in those that developed TB. But if you gave them 4 months of rifampin only, you had no evidence of active TB disease and no evidence of hepatotoxicity. And this was one of the studies that showed that the rifamycins, rifampin and rifampin together, are actually pretty effective in treating latent TB infection amongst this population. In another study that was more current, 10 years after that, in 2006, showed 4 months of rifampin versus 9 months of INH. It was a retrospective review, non-randomized study, but showed significant reductions in risk for progressing to active disease amongst those who took both INH and rifampin. And it worked in HIV positives as well as in HIV negatives as well. So it was a substantial reduction overall, and with 4 months of rifampin, you still had a higher completion rate. So there's some tension now as far as like what's first line, but generally first line now for INH for prevention of TB disease, both in HIV negatives and HIV positives, is 9 months of INH. That's considered first line. But rifampin or rifamycin for 4 months is a close second, depending on the setting. Again, with HIV positives, I would use INH because there's more data to support that, and using rifamycin in the setting of HIV, as we'll talk about in a moment, can be very tricky. So what about adherence to LTBI therapy? In a more recent paper by Bob Horsberg and his group up in Boston, actually I think it was published late last year, showed that what we all of us know is that you're going to have a lower percent completion depending on the duration of therapy. So 9 months of INH, you're going to get less than 50% completing. 6 months, you're going to get a little bit better. But the best adherence is going to be with 4 months of rifampin, where you get close to 70%. At least 2/3 of patients will complete a regimen. And to me, the most effective treatment is the treatment that you can get into a patient. And if they're taking it, well, then that's what really counts. again, on this point, you have a very important slide here. And again, many of you who do and follow these patients with LTBI and do LTBI therapy know that your failures are going to occur all throughout your 9 months of treatment with INH, but most people are going to fail. The most common month is in the first month. They're going to kind of not comply. They're not going to comply early. But again, you have about 5% drop-off per month thereafter. So this is very substantial and a big challenge to treating LTBI in the current with the current tools. But as many of you know, there's about to be a change in the guidelines for LTBI therapy, and that's not just with HIV. It's mostly with HIV negatives, but eventually will work its way down to the HIV positives. There were some earlier studies that looked at Rifapentine use. Rifapentine is a longer-acting rifamycin. It's like Rifampin, has similar side effects, but just has a longer side effect, a longer half-life, and then it's also going to have a sort of smoother metabolism where you don't get the dual peaks that you get with rifabutin. And they compared PZA and Rifampin daily with Rifapentine and INH once weekly, and basically found greater toxicity with PZA and Rifampin as we found in the U.S. This was a study that was done in Brazil, and found that Rifapentine INH was safer and then had probably better efficacy, although it was not powered to show that. Now, in the Prevent TB study, which was TB Trials Consortium Study 26, and I can't remember if there was an Alabama site on this study or not, so one of y'all can correct me if I'm wrong. But in this study, looked at multi-center randomized clinical trial looking at 12 weeks of once-weekly Rifapentine at 900 milligrams plus once-weekly 900 milligrams of INH under directly observed therapy versus 9 months of INH self-administered therapy, and found that the bottom line is a non-inferiority study, which wasn't powered to show superiority, but just to show that it was no better and no worse. It's being reviewed right now, but it was a great study. Had 8,000 patients. 97% were eligible to complete the follow-up, and 72% were contacts to cases. The long and short of it is that it wasn't inferior. It's probably going to become the standard in many health departments. The problem is that there weren't enough HIV-positive patients to say with absolute certainty that this regimen is effective. Will it be wrong to use it in HIV positives? No, but you have to be very careful in patient selection and also do it in very close coordination with the health department and with an expert familiar with the use of Rifapentine and INH. So let's talk a little bit about active TB disease treatment. Basic principles, really it's the same thing for the most part. The main issue that you need to be wary of is that the intermittent regimens that we use for HIV negative individuals is not going to be as effective, and is going to lead to potential drug resistance. And also you just have to have a very low threshold to extend therapy. It's going to be very important that they don't respond to therapy appropriately. Therapy will need to be prolonged. This is a little bit of a busy slide, but from a very good reference article, so please take note of that reference. Tim Sterling did a great job and did a very good review that was just published late last year, from which many of these slides came from. Basically kind of reviews just the overall idea that basically you induce with daily therapy with 4 drugs for the first 8 weeks. If pan-sensitive, you then discontinue the PZA and the thiamutol, and then continue with no less frequent than thrice weekly. There are other options. You can begin with thrice weekly right off the bat, but generally what I would recommend and what we normally do in practice is go daily therapy for the first 8 weeks for pan-sensitive HIV-infected individuals, and then go to intermittent therapy with 3 times a week thereafter. Prolonged therapy if they have a slow response, high burden of disease, or complications that have interrupted therapy at some point. And again, some of the duration of therapy has to be sort of played by ear. Yeah, we're almost losing power here. If you just check the power cord, please. So when should antiretroviral therapies be started? Because this is one of the more important issues that kind of comes up with HIV co-infected TB patients. There's show kind of where we're having some power issues, but we should be okay. Among HIV positive patients, the mortality rate is going to be very, very high. So if you don't get HAART and you've got HIV TB, mortality is extremely high. That's more in less developed countries and areas, particularly sub-Saharan Africa, but we know that the outcomes are bad. There are 3 controlled trials, randomized trials that just wrapped up that looked at co-infected patients. They were done in Africa. I don't think any of these studies had any U.S.-based patients, but basically helped to answer this question about when therapy should actually be started. And so in the CAMELIA trial, just to use one example, there were 660 patients with new smear-positive TB with a median CD4 count of only 25. They were randomized to either begin ARV therapy at 2 weeks or 8 weeks or after the start of therapy. More than 70% of the patients had baseline CD4 counts, and it's okay. For 13 days and 56 days, respectively. During a median follow-up of 25 months, the earlier ART patient had a significantly lower mortality, 18% versus 27%. And the IRIS risk, that's the immune-mediated response, sort of a paradoxical response that occurs in patients with HIV, was higher in the earlier ART group. But basically, the idea was that IRIS was worth the risk to reduce the mortality overall. So you had more issues with immune reconstitution syndrome than you did in those that you didn't do antiretrovirals, but it was worth the benefit for mortality. So the bottom line, start the antiretrovirals as soon as you can, manage the issues related to how many medicines they have to take and some of the compliance issues, but really that's particularly true in those people that have CD4 counts below 50. The TB and HIV drug interactions are probably the single most important issue for people in managing these patients. This is going to be a big issue, particularly with the HIV protease inhibitors, but also with the non-nukes, the integrase inhibitors, and now the CCR5 inhibitors as well. I've got some of the data there that kind of talks about kind of where we're at, but just remember that Rifampin significantly decreases the protease inhibitor levels and should not be given at all. Rifampin can be given with the NNRTIs, but with efavirenz, but there's significant evidence that it's going to be better with efavirenz than, say, with nevirapine. And then with the integrase inhibitors, always look at kind of not giving Rifampin with it and use Rifabutin instead. Again, I really want to emphasize the point that with these patients and the complex drug interactions that occur, a lot of it is sort of up in the air, and then therapeutic drug monitoring is very important. A very busy slide that I put here more for your reference, but also I want you to look at some of the active websites. The University of California, San Francisco has their HIV Insight website that has updates on the drug interactions. So does the CDC have a website where it kind of talks about the latest drug interactions that occur. Consult with the specialist who's used to treating patients with HIV-TB. With my HIV-TB patients, I frequently will go and check the most recent data as far as like what drug interactions, and I will very frequently, if not always, check therapeutic drug levels on these patients when I'm trying to manage their drug interactions. What about the risk of recurrence in HIV patients? This too is a pretty common issue that comes up with HIV-positive patients. The primary risk factor for TB recurrence among HIV-positive patients appears to be a low CD4 count. So if they start with a CD4 count below 100, that's going to be critical with worrying about failed therapy and, more importantly, recurrence later on. You may need to prolong their therapy. You need to ensure DOT is there, ensure good nutritional support, and sort of push that along better. But really the bottom line is this, next slide, is that right now the tools that we have available to treat TB, particularly TB and HIV, is very, very limited. This pipeline sort of our timeline shows the sequence of events of TB drugs as they've been developed over the last 60 years or so. What happened? I'll just keep going. And so this kind of shows the sequence of events of the TB drugs as they've been developed. But overall, what we really need to have is going to be new drugs, and there's a lot of new drugs coming down the pipeline at this time. So I will go ahead and close with that slide. And again, I'll take any questions there. And again, I appreciate your patience with some of the technical issues that have been going on, and be glad to take any questions or comments that you might have. Thanks for your time.
Does anyone have any questions? one question to Dr. Lauzardo. Let me know if you can hear her.
Sure.
Regarding recurrence, I know you talked about HIV, but just in the general population, is there, I mean, what's the likelihood of recurrence, and do you ever retreat after someone's received INH?
Yes, I heard that. So the question is that regarding recurrence, sort of not just in the setting of HIV, but in the larger setting, does recurrence occur? Do we treat them again after in the setting of INH? With regard to active disease, even in the best functioning programs, recurrence occurs about 2% of the time. That's probably the best case scenario with the current drugs that we have available and with DOT and some of the variability. With those, you basically would start over with treatment, prove that it's a recurrence, that it's the same strain that they had before and not a reinfection. That's particularly true with HIV positive patients. But if it is, you would end up treating them again, usually with a similar treatment course. I tend to treat a little bit longer for recurrent cases because there's something about them that's different, that they failed. And I just kind of think that more bugs, more drugs, so they just need to get more treatment. Now, in patients who fail INH preventive therapy, who develop active disease despite, adherence, the most likely cause is that they weren't really as adherent as you thought they might have been, but that I would then go ahead and just treat them based on their susceptibilities if they develop active TB disease, and then just use the susceptibilities to guide me. I hope that answered your question.
Yes, thank you.
You're welcome.
Dr. Khan?
Mike, I'm curious, in the CAMELIA trial with the 6 iris deaths, were they all CNS disease or were they from other causes?
Yeah, I'm not sure about the actual deaths. I need to go back and look at that paper a little bit more detailed. And Ed, great to hear your voice. I was hoping you would be there. Yeah, it was kind of a little bit mixed bag because when they showed that percent, that it's 27% mortality versus 18, that's it was clinically significant, but still 18% is still very high. And again, you still have 6 iris deaths that you didn't have in your larger mortality group. So yes, I think you should start therapy sooner, and especially in those with low CD4 counts. And perhaps those deaths would not occur in the U.S. because we have a little bit better support and hopefully have better access for our patients to get supportive care. I would assume that those iris deaths were CNS because that's going to be the most common cause of death for most patients. Although I have seen sort of like a sepsis syndrome in someone who had iris before as well. So I'm not sure. I do need to look that up, though, but I'm assuming that they were CNS deaths.
Great, thanks a lot.
Yeah, sure.
Anyone else? Okay, Dr. Lauzardo, I think that's it. Thank you very much for working with us today and working around us and our technical difficulties.